Hi, my name is Natalie Graber, and I am a natural sciences and psychology major here at Bethel College. Today, I'll be presenting my seminar thesis alongside with my URICA presentation. So the title of my project is Patient-Therapist Relationships on Patient-Perceived Rehabilitation Success, Applications in the Physical Therapy Setting. To give a little bit of background on this study, I wanted to explore topics in the field of therapy, specifically physical therapy, as that is what I am looking to go into for grad school. And I needed to combine my natural sciences and psychology seminars so that I didn't have to do two. And so this led me to researching the effects of patient-therapist relationships on the success of rehabilitation. To give a little bit of an outline of what I'll be talking about today, I'll go through my short and sweetened version of the literature review. I'll overview my hypotheses. I'll take a look into my methods and my data processing. I will not be talking about conclusions, and I'll only talk about preliminary results today, as I'll discuss a little bit later about why that is. And then I'll go over some of the limitations of this study, and then also go over some closing reflections. So first off, in my literature review, I decided to talk about this intersection of two methodologies and recognize that physical therapy standing alone is an individual methodology that includes clinical research alongside evidence-based practices that are directly applied to the treatment of patients with a variety of injuries, disabilities, and other health conditions. And in contrast to that, psychology's methodology focuses more broadly on human behavior and interactions. So while each methodology has its own criteria, applying psychology to physical therapy can tell us more about patient-therapist relationships. Okay, and so to cover a little bit more about rehabilitation success, the main goal of rehabilitation is to facilitate recovery after a loss of some function. The primary goal of physical rehabilitation is to restore muscle and joint function for the purpose of stability during movement. And this starts with basic movements such as balancing, and then kind of gradually works up to more complex movements like walking up and down stairs or getting into cars. And so this timeline of rehabilitation looks different for everyone depending on how significant the loss of function was. Okay, and so now I'll be talking about the concept of the Therapeutic Alliance. So this was one of the studies that I based a lot of my research off of. And so there's this concept called the Therapeutic Alliance, and this basically talks about the working relationship between the patient and the therapist. And so this concept was actually originally derived from psychotherapy and had a lot of positive outcomes associated with positive relationships between patients and therapists. And so this was back in 2010. And then this kind of concept started to be applied more to physical therapy in the Bonatunde study. And they also noted that there was increased patient adherence through the Therapeutic Alliance as well. And so that's a really crucial aspect to the working relationship. And I'll cover that a little bit more later as well. This 2017 study also covered a couple more of the research limitations, and I'll cover those some later in the presentation as well. Okay, and so as we covered rehabilitation success previously, I'll be taking a look more into the patient-defined rehabilitation success and talk about why this is an area of interest. So the patient-defined rehabilitation success model defines rehabilitation success through the patient's perspective. And so this emphasizes a patient's desires, beliefs, and expectations and utilizes them in making decisions on what constitutes a successful treatment outcome. And so this Epiari and George research study used a patient-centered outcome questionnaire, or PCOQ survey, which is actually the survey that I used in my research as well, and covers a couple of different topics in the rehab setting, and kind of looks at the patient's expectations, success criteria, and also monitors what they would rank their pain, their fatigue, emotional distress, and fatigue throughout their rehabilitation process. Okay, another thing to note when talking about this topic is the psychological aspects of patient-therapist relationship. So patient adherence in relation to psychological needs. So this study by Hall kind of talked about the self-determination theory and basic psychological needs theory as used to describe an individual's motivation. So this kind of looked at the patient's level of competence, connection, and autonomy, sorry, and talking about when those needs are met, that they feel comfortable in their environment and being able to kind of push themselves a little bit more when they feel like they have those needs cared for. And so this is really crucial in talking about the patient-therapist relationship, because when they feel that comfortable in the rehabilitation setting, and then they can try to stride more towards those, to making those improvements in their rehabilitation. And this is something that PTs can help with as well. Okay, so now I'm going to move on to talking about this study done by O'Keefe. And so this identifies themes of patient-therapist interactions and kind of gives a reflection on what physical therapists do to help patients feel more successful in their rehabilitation. And so this was a meta-analysis of a lot of different scoping literature. And so basically what they factored down to was physical therapist interpersonal and communication skills, motivational techniques, physical therapist practical skills, individualized patient-centered care, and organizational and environmental factors. And so these were all the categories, sorry, 5 categories that ended up making a difference for the patients in their rehabilitation. So to just briefly touch on each category, so category 1, physical therapist, interpersonal and communication skills. This had a lot to do with motivational strategies and techniques, and how encouragement and motivation was a crucial factor in adherence to the rehabilitation program, as kind of mentioned before. And so, yeah, these strategies used by the therapists are components of influencing rehabilitation success. Okay, category 2, the practical skills. This includes an emphasis on importance of patient education. So this is really crucial because we need the patients to know what's going on and be able to explain to them in a way that they can understand. And this gives the patient autonomy again, and kind of gives more confidence in their rehabilitation process. And then also therapist expertise and training. The patients need to feel like confident in their therapist abilities and training in order to help them get the best rehabilitation experience possible. Okay, so category 3 here, individualized patient-centered care. This was something that I had just learned researching for this project here. And so I found this really interesting for me, and I think it will be applicable to my, my career as a PT someday. So this kind of ties back to the Affordable Care Act, and it talks about the change of care payment and reimbursement method from volume-based to value-based purchasing. And so to kind of give a brief overview of all of this, the creation of the Medicare Shared Savings Program, MSSP, through Centers for Medicare and Medicaid Services. This created a system where healthcare providers were liable for their own financial compensation based on their evaluated incomes. So of course, they wanted to start testing methods to try to improve these qualities of care and outcomes. And so basically what ended up kind of coming into being was more patient-centered approaches to care. And so then we really tie that into this project. And I think that was a really cool connection to make. So the last category here, organizational and environmental factors. Time was a big component. Patients wanted the ability to express their needs as well as discuss their plan for treatment. And so that's a really important aspect to rehab, making sure that the patients feel like their needs are cared for and that they understand what's going on and they're able to connect with their therapist in that way. Another side point was the flexibility of appointments. Some patients actually mentioned they wanted to be able to reach out to their physical therapist after rehabilitation to kind of talk about other ways that they can use preventative methods and stay healthier. So. Okay, and then to briefly touch on some of the factors on the patient side. So we were just talking about the factors on the physical therapist side, what they can do to influence their relationship with their patient. And now we're going to look at the patient side here. So they categorize some factors that the patient has control over in their rehabilitation success. So most physical therapy clinics that I've been in, at least outpatient, the patients get about 2 to 3 appointments per week, and this is often based on their insurance allowances and what they can afford to pay for their rehab. However, having rehabilitation exercises daily is really the best way, keeping your body moving and keeping that injury moving to increase that rehabilitation success. It really needs to be done about every day, even if you can't get into the PT clinic every day. So a lot of PTs will provide at-home instructions that need to be and exercises that need to be completed daily for this. And so these played a significant role in rehabilitation success, of course. And then also in turn, we have the adherence to the rehab program. So significant influence on the success of rehabilitation. So these two aspects are closely tied together because when you're doing your rehab exercises at home, you're feeling better, you're working to get your injury better, get your body back to be healthy. And then that in turn kind of creates that motivation when you see the therapist and they say, wow, you've improved a lot since I've seen you last. And so those two are really, really closely tied together in terms of the patient and rehabilitation success. Okay, and so now I'll kind of talk about my research and how it's kind of changed over the course of the past year and a half. And so originally I had planned to take these surveys into PT clinics and get the data there. However, with COVID, I've really had struggles getting into the clinics. They've been overwhelmed with patients and overwhelmed with everything that's been related to COVID in general. And so unfortunately, I wasn't able to get into PT clinics. However, the Bethel College Athletic Training Clinic let me take my surveys there. And so they've been collecting data for me. And this was just a recent revelation. So I don't have all of my data yet, but I have some preliminary data that I'll be talking about a little bit later. And so that's why I added this slide in, so to talk about the differences between, or that are potentially there between physical therapy patients and athletic training patients. And so when I was researching this, I actually found something a little bit interesting. So they said that athletes are specifically more susceptible to facing setbacks in their rehab. And so I found this really interesting because they said it can cause decrease in motivation and hinder attachment to their rehabilitation program. We can see this in like reoccurring injuries, especially in runners that have a lot of chronic injuries. Or even just injuries that are kind of underlying, but then they keep flaring up and then kind of go back down with rehab and flare up again, kind of that back and forth. And so then it also kind of talked about how athletes face a lot of other pressures than maybe normal patients would face. If there's a pressure from a coach to play again, or teammates to be able to play, you don't want to let your teammates down, or you don't want to let your coach down by being out with an injury, and of course, self-pressure as well. And so looking at all of these outside pressures, especially for an athlete, the ATs are the go-to person in order to get healthy, and they're going to be the ones that will either clear you and say you can play or not. And so for this reason, I predicted that AT data, the students would actually have more of a relationship and probably rank their relationship higher with their AT because there's just a little bit more of a personal connection there, especially as a student athlete. Okay, so here are my working hypotheses for this project. So the average score of pain will decrease from the first survey to the last. Confirmation of physical rehabilitation specific factor. So the specific factor that I'm talking about is the methodology of physical therapy or just rehabilitation in itself, that the point is to decrease pain from the beginning of rehab to the end. So just kind of confirming that that methodology is sound first before kind of going into more of the relationship factors. The average score of function will increase from first survey to last. And this is, again, just like the first, confirmation of physical therapy specific factor. And then this was the variable that I was most interested in, is the emotional distress variable, will be inversely correlated with the mean patient satisfaction score. So we're looking to see that as the rehabilitation process goes on, emotional distress decreases and as patient satisfaction increases. And then this is kind of what I was just briefly pointing out, is that AT values of patient satisfaction will be higher than those of PT. And so that was back when I was intending to collect physical therapy data and potentially athletic training data. So I won't be able to compare those now. So I'll just be looking at the values of the athletic training patients. Okay, so to talk a little bit more about, again, the current study, I really wanted to see what extent does the patient-therapist relationship have on the feelings of successful rehabilitation by the participant or the patient. So the surveys were collected from Bethel College Athletic Training Clinic and are still continuing to be collected. And so these packets include the initial and final patient-centered outcome questionnaire, as discussed earlier with Giorgio Zebrari study. And so those are the two parts of that. And then at the end of rehab, the patient will take the patient satisfaction survey. This just asks questions about how they viewed their interactions with their PT or their AT. And then, let's see, yep, I think that's all for that slide. So I'll move into my methods a little bit. So what I did was I distributed the survey packets to the athletic training clinics. And so I had specific criteria that athletes with musculoskeletal injuries filled out the PCOQ survey, of course, after giving consent. And I specifically wanted it to be musculoskeletal injuries, and I wanted them to be acute because I felt like there might be some noise in the data, especially with things like chronic pain. It might be a little bit harder to gauge if something's getting better in that sense, if it kind of, like I was saying before, kind of flips back and forth, if it flares up and kind of goes back down again. So I wanted all of the data to be from acute musculoskeletal injuries. So athletes took the follow-up PCOQ survey and patient satisfaction survey after they were done with their rehab training process. Athletic training staff passed surveys to me when they were completed. And again, this study is still in progress. I have 5 surveys so far and about 9 more in progress. And so I'm excited to see what those will yield. Okay, so to talk a little bit about my data analysis plan, I've started to kind of look into the structure of the surveys themselves. And so this here is some code that I've been running. I want to see which kind of variables here that I have. These are all questions that are asked of the patients, which have the highest correlation and lowest correlation. And so basically, I'm just looking to try to get the most accurate representation of each factor that I can. And so which one would give me the most reliable data. So then I needed to also separate out my data frames because each section asked about pain, fatigue, emotional distress, and interference with daily activities. So I needed to kind of separate each of those out into different data frames so that I could analyze them all individually. And then I also needed to frame out these patient satisfaction survey questions, which is a little bit more complicated because these are on a Likert scale, and also there are some reverse scale questions. So basically what I needed to do is pull out, so if you can see at the bottom of the screen, the PSS4 and the PSS8 were each my reverse scale questions. So I needed to pull those away from the others so that I could reverse scale them to match the others so it wouldn't skew my data in a weird way, and then combine them back in the data frame. So here I'm doing that. I rejoin the PSS4 questions after doing the reverse scale, for lack of better words. And then I also, at the bottom of the screen, add back in the PSS8 columns. And then just because of the way that the data is read into my RStudio, I needed to convert it over to long form so that I can basically pull linear regressions and compare these in long form to these PSS questions in long form. So I will be going through the rest of that data processing at a later time when I get the rest of my surveys. But so far I took the means of the columns. And so I found some really interesting things so far, interesting observations that'll be interesting to take a look at more later when I can do those linear regressions. So all the PCOQ means were lower following treatment. So pain, fatigue, emotional distress, and interference with daily activities, each of those were graded as lesser of a hindrance later following treatment as opposed to before treatment. And all PCOQ estimated initial values ranked lower than actual initial values as well. And so something else I thought was really interesting to look at, all of the PSS scores, aside from PSS4 and PSS8, because I ran this code before I reverse scaled them. So essentially this PSS8 would be 5, and this PSS4 would be about 4, a little over 4.5 or so. And so these are all ranked really high, which is, I find really interesting. So it looks like to me, initially everyone has had a good experience with their athletic trainer. And so that's really promising to see as well. So I think that will yield some really good data later on. Oh yeah, and just again to talk a little bit more about my further analysis when I finish collecting all the data. I will run some linear regressions between these PCOQ questions and the PSS surveys. And basically all post-treatment responses of pain as predicted by the patient's responses about their experience with their AT. So that's kind of what I'm looking to do going forward. I'll also kind of look at some comparisons between pre-levels of pain, fatigue, emotional distress, and interference, just to kind of see if there's any validity there, something interesting to find there. And then I'll also find which questions give me the best prediction of this relationship. Okay, to talk about my limitations a little bit, some of the surveys and studies that I cited before talk about the lack of literature on this subject as a whole, and I would say also lack of methodology in order to really fully solidify an existence of the extent of this relationship that the patient-therapist relationship has on the success of rehabilitation. And so it's really difficult to determine the solidified relationship without a solidified methodology. And the only way to really for sure find this out would be to randomly assign patients to either a terrible physical therapist or a really great physical therapist. And obviously there are ethical limitations there, so that can't be done. So we kind of need to just work in these areas of finding correlations and finding those kind of relationships through what we just see on our day-to-day basis at the AT clinic. Yeah, and I couldn't collect data, of course, in the PT clinics due to COVID-19. So all of this is just going to be a little bit different because it will be with the athletic training clinic instead. Okay, and then I wanted to end by adding this extensions slide and talk about what am I taking away from this project, because I think I'm getting a lot more out of this project that I can apply to my personal life later than I ever thought I would. So in reading all this literature about patient-therapist relationships, it's really giving me a lot of things to be aware of as a future physical therapist, and keeping in mind that the way that I interact with patients on a day-to-day basis will matter, and it matters to them and it'll matter to me, and it could hopefully it can hopefully make their rehab better. And so that's something that I've wanted to keep in mind moving forward. And then kind of talking about looking into the Affordable Care Act and healthcare legislation as a whole. That's something that I want to be more aware of as a healthcare provider going forward, and know some of the things that my patients are going through on that side of care, and be more aware of that. And then my other takeaway from this is that plans change, and COVID has definitely taught us that that is true. And so it's really taught me to be adaptive, be open to new solutions, new ideas. And so I think I will take that in mind going forward as well. Okay, and I would like to say thank you to the URICA committee for giving me the opportunity to do this research. I am so grateful for the grant. It allowed me to do some of my shadowing at NMC Health and will allow me to compensate the athletic training clinic for helping me collect data. So I'm just really grateful for the URICA committee and their work in promoting undergraduate research. So thank you, URICA committee. I'd also like to thank my advisors, Francisca Mendez-Harkler-Rode, Brad Celestin, Dan Sigley, and Dwight Crable. Having a double major has not been easy. Following the direction of 2 departments, but I feel like each has had unique and wonderful knowledge in their field, and it's only made my research and me stronger as a person as well. And a big shout out to Francisca. She has been my advisor and also just really helped me be adaptable with this research project. And I would also like to thank my student assistant, Gracie Higgins, for helping me input data, reviewing my paper and making edits and making suggestions, making sure everything makes sense. So a big thank you to her as well. Okay, well, thank you so much for listening to my presentation today, and I hope you have a great rest of your day.